three parts in the class. First one is a presentation in the examination style, followed by a small discussions about a specific topic which is not a part of this teaching program. And this thirdly, there will be some OSKI sessions. And for the part one, we will discuss today the PD complications. And we're very privileged to have Professor Dipankar Bhaumik with us. He is currently heading the Department of Nephrology in the All India Institute of Medical Science, very close to very close to us. And every time we request sir for taking a class or for any academic session, he always agrees. So we are grateful to be grateful to accept you in this class. And for this today's session, Dr. Nivedha from CMC Vellore, she will be presenting a case. And I am also grateful to your teacher, Dr. Santosh Varghese, who allowed you to present the case in our classroom program. We are having Dr. Aniruddha Datto, who will be conducting the OSKI sessions and the subsequent program. So without wasting time, I request Dr. Nivedha, please take the permission of your teacher and you can start the presentation.
Good evening, sir. Shall I present the case?
Yeah, you start the case. So what you do is first present the history, then we'll discuss the history, then the examination, and then we'll discuss some more details, investigation. So you start presenting the history.
Sure, sir. I'm presenting a case of 70-year-old male. He's a retired PT teacher. He's a resident of Tamil Nadu. My history dates back to year 1999. He was incidentally found in year 1999 at the age of 50 years. He was incidentally found to be diabetic on routine evaluation, and he was started on OHA initially. His sugars were fairly controlled, but since past 5 years, he's on insulin, satisfactory blood sugar levels. In year 2009, he was found to have systemic hypertension. Since the past 16 years, he's on single antihypertensive. He was on single for the past 16 years. He's on single antihypertensives. There is no history of uncontrolled blood pressure episode. In November 2023, he was found to have raised creatinine, and on evaluation, he was told that there is protein leak and renal dysfunction, likely due to diabetic kidney disease. And he recalls his creatinine was around 6 at that time. He was in regular follow-up, but creatinine was worsening. His opthal evaluation was also done. He had mild symptoms of diminished vision, and he was told that there are changes in the fundus. However, he did not follow up with the opthal OPD thereafter. In May 2024, he complains of generalized body edema and features of fluid overdose with reduced urine output, for which he was initiated on hemodialysis initially via right non-tunnel jugular catheter, which was later changed after a week to tunnel jugular catheter. And he recalls that his creatinine was around 10 at that time. He was explained all options of renal replacement therapy at that time, and he was keen on starting PD as the mode of RRT. In June 2024, he was planned for a PD catheter insertion, but it was a laparoscopic procedure. As he tells that there was a right inguinal hernia for open surgery was done, and this PD catheter was inserted in the peritoneal cavity. After 4 weeks of catheter insertion, he came back to the hospital where flushing was attempted with the saline, and there was no outflow. He was given laxatives for a day, and some fluid with injection was instilled into the PD catheter, and an X-ray was done. And on X-ray, he was told that the PD catheter is not in position. He told that after which he was planned for another laparoscopic surgery, and he was told now the catheter has been repositioned, and there is a gut component which was wrapped around the tip and which has also been released. After 2 weeks of flushing, after 2 weeks, he was called back in the hospital and flushing was done, which showed a good outflow. He was started on PD exchanges since then. He stayed in Vellore city after starting PD exchanges for about 15 days, and proper training was given to his caregiver, which is his son-in-law. He is a physiotherapist by profession. Initially, the PD prescription, initially he was started on CAPD, and his PD prescription was 1.5% of glucose, of dextrose. There were 2-liter bags were used, and 3 dwells were given. Each well was given for about 6 hours. His urine output at that time was 300 to 400 ml, and initially there was no ultrafiltration. So over a week, the concentration was gradually increased, and after a week, it was 2.5% dextrose. And the ultrafiltrate that came was 700 to 800 ml per day. He says that another expensive test was done after 1 month, which shows satisfactory results. And he was continued on the same prescription. After 2 months, they had hired a qualified male nurse who was given the same training in the same hospital for a few days. And he comes 3 times a day to perform PD for this patient, and had no problems in the hygiene or any other issues with the qualified nurse. There is no history of constipation.
Just a minute.
There is
So the
history of
percentage,
constipation.
Nivija, yeah, so the glucose
Sorry.
concentration was 2.5% all 3 exchanges, or
Yes,
how was it?
Initially, it was 1.5, 1.5,
afterwards.
1.5, 2.5, 3 exchanges.
All 3 were 2.5.
Yes, sir.
And night dry.
Night dry.
Yeah, okay. So night dry. Okay, continue.
And there was history of constipation on and off, for which he used laxatives. And there is no history of any blood transfusion or in the past. In March 2025, he presented with complaints of pain abdomen since 2 days, cloudy effluent since 2 days, and loose stool since 2 days. The patient was apparently all right 2 days back when he presented with sudden onset, gradually progressing dull aching, mild to moderate to severe intensity, diffuse non-localizing abdominal pain, and there was no relation to change in position or food with the pain. There is also associated history of passage of large volume, foul-smelling watery stools that were 3 to 4 times a day since 2 days. They are not blood stained, and there is no history of tenesmus. The caregiver also noticed that there was a change in color of the effluent, and since last 2 days, he is not able to read through and through the effluent bag. There is no pain, or there is no history of pain during inflow or drainage of the dialysate, and there are no flow issues. There is no history of any exit side redness discharge. There is no history of fever or headache or nausea, vomiting, no history of decrease in urine output, and has a satisfactory ultrafiltration. There is no history of orthopnea, breathlessness, or any weight gain. The caregiver was inquired, and it was inquired by the from the son-in-law that he wears a mask every time he does the PD, and he's maintaining proper hygiene and hand washing. PD was performed in a separate room with closed doors and windows, and there is no and during past 1 month there has been no he could not recall any history of any accidental dissection or any history of contamination or breakage or leakage of the tubing or the bag. There is no history of recent change in the supplier, no history of any recent travel or infectious contact with the infectious person. There is no history of any recent hospitalization, and he doesn't have any pets at home. Dietary history. He's a non-vegetarian, takes about 3 to 5 egg whites per day. He takes slow salt diet, and there is no addition of added salt. Sleep, there is no change in sleep pattern. The appetite has decreased since the past 2 days. There is no change in bladder habits. Bowel, he has constipation and is on laxative on and off. Family history, there is no family history of renal disease. There is no history of intake of any alternative medications. There is no history of alcohol smoking or any illicit drug use. Drug history, there is no history of any allergy to any antibiotics or any allergy to any food. There is no history of any gastritis or any history of any antacid or any PPIs.
Okay, so you finished.
To summarize,
Summarize.
He's a 75-year-old male who is known case of diabetes and systemic hypertension. He has chronic kidney disease and is on CAPD with the prior history of probable laparoscopic repositioning of the PD catheter tip and release of the mental wrap, and currently came with complaints of pain, abdomen, cloudy effluent, and loose stools. The possibilities in the background of CAPD are PD peritonitis, or could be that is the main possibility, so that we are considering.
Okay, so let's start from the basics. Okay, so he is a diabetic for the last 26 years and hypertensive for the last 16 years, and he has some fundal changes. So what is your basic native kidney diagnosis?
So, sir, it is a probable diabetic kidney disease that we would think of, because a long-standing diabetes with diabetic retinopathy points towards diabetic kidney disease.
Right. So what is the difference between diabetic kidney disease and diabetic nephropathy?
Diabetic kidney disease is a bigger spectrum in which diabetic nephropathy is part of it. It includes the non-diabetic kidney diseases also. Sorry, the non, sorry, no. Sorry. What I mean is, it is a bigger spectrum of diabetic kidney disease in which diabetic nephropathy is part of it, sir.
More specifically, what is diabetic nephropathy as per the current understanding? Diabetic nephropathy is basically a biopsy diagnosis. As you rightly said, it's a part of the spectrum, but so if you have a biopsy with the classical changes and with the classical WHO classification, then it is diabetic nephropathy. Okay. So what are the other features of diabetic kidney disease? When you can say, that most likely diabetic kidney disease, you have mentioned the long-standing diabetes, you mentioned fundal changes. What are the other features which will make you a little confident that it's diabetic kidney disease?
So he has also history of protein leak. Okay,
albuminuria. Okay, what else?
And
what are the features of diabetic kidney disease? And you see daily, this is a very routine question. What are the other features?
Yeah, there will be renal dysfunction, sir.
It could be. That doesn't rule out or rule in. It doesn't. What else? Urine sediment will be bland. Because it will be a non-diabetic kidney disease. So there will be no RBCs in the urine. Right?
Mm-hmm.
There will be no dysmorphic RBCs. What else? The ultrasound. On ultrasound, what will you find?
There will be normal sized or normal sized kidneys.
Right. So normal sized kidneys. Right. Mm-hmm. Now tell me, when you said that patient has got mild or moderate NPDR, what do you understand by NPDR? And what are the different stages of NPDR?
So NPDR, there are 4 stages of diabetic retinopathy. NPDR usually is the presence of retinal hemorrhages.
So what are the different grades of NPDR? You said no patient has got bilateral moderate NPDR. So what is mild NPDR?
So there is mild NPDR would be microaneurysms, the presence of only microaneurysms.
Yeah, so only microaneurysms is mild NPDR. Okay, what is moderate?
Moderate is there will be retinal hemorrhages. There will be this
what else?
Dot and blot hemorrhages.
Okay, right. What else? What else? Carry on.
And there will be some exudates.
What types of exudates?
It's hard exudates which will be present.
What are hard exudates?
Um,
So when you say
they are-
hard, there must be something soft also, no? So what is soft and what is hard?
I'm not sure, sir. I think lipid deposits is because of the hard exudates.
Yes, absolutely right. So lipid deposits are hard exudates. And what is soft? Which are worse? Which is worse? Soft or hard? You're right. Carry on.
So hard would be worse.
No, no, hard is not worse. They are only lipid deposits, as you rightly said. Soft exudates are microinfarcts of the axons, right? So soft exudates, the cotton spots, they are much worse, right? And then you have severe. Severe is when you have them in all quadrants. There's a 4-to-1 rule in that.
4-to-1 rule, that is a
right. And then you have the proliferative retinopathy. Very good. So the patient probably has diabetic kidney disease and now has presented you with pain in the abdomen. Now, when you come to CKD, what are the late presenters? What do you understand by late presentation of chronic kidney disease? See, here you see, symptoms started in November 23, isn't it? And then dialysis started in May 24. So, what do you understand by late presenters of chronic kidney disease?
Depends on the duration from which the first creatinine to the worsening of the
right. Absolutely right. So, can you be more specific? How much? So late presentation is if the patient needs initiation of dialysis within 6 months, maybe 3 to 4 months of presentation. So if the follow-up of a nephrologist has been less than, some say 3, some say 4 months, then they're called as late presenters, which has an outcome on the bearing of the patient. Definitely has that. Right. So now, what you haven't mentioned is that this PD catheter was inserted by a lab technique or maybe surgical technique initially. So what are the different types of PD catheters that you are aware of?
So there is a straight catheter. There is
what is the name of the catheter?
Tekken.
No, it is not Tekenkov. It is not Tekenkov. It's Tenchkov. Tenchkov catheter. Okay? Tenchkov catheter. Which are the other types of catheters apart from Tenchkov?
The other types, like swan neck catheter and
there is swan neck catheter. Very good. Anything else?
Then there is coil tip catheter.
No, coil tip catheter could be part of Tenchkov, which is straight, or a swan neck would also have a straight intraperitoneal part or a coiled part. Okay, so straight tip or a coiled tip would be a part of either. So here, which catheter was it? That I don't think you mentioned.
Swan neck catheter.
You had a swan neck catheter placed?
Yeah.
So routinely, are you placing swan neck catheters?
Yes, sir.
You don't insert Tenchkov catheters?
Straight ones we are not using. So swan neck is what we are using.
No, I think you're confusing. You may be using a coiled intraperitoneal tip.
No, coiled we are not using, sir.
You did not mention exactly. What do you understand by a swan neck catheter? What is a swan neck catheter?
So this has this the shape of it resembles a swan neck. That is the part.
So where is the curvature? Where is the curvature? Where is it curved?
Between the two between the two cuffs, sir. It is
between the two cuffs. Oh, how can you have a curvature between two cuffs? Where are the two cuffs placed?
One is the external cuff and one is the internal.
That so one is external, one is internal. So you can't have a curvature between the two cuffs, no?
Yeah, but once we insert it, after that
Okay.
it comes into the abdomen.
Okay, so you are sure it was a swan neck catheter which was placed. Swan neck
Yes.
straight tipped. Anyway, you have to be very sure what type of
Yeah,
catheter
straight
you
tip,
are.
not a coil tip, not a
Not
coil tip, straight tip.
right. So, what have the studies shown? I mean, which catheters have more displacement? So, he had a catheter displacement, isn't it? That's what you mentioned. He had a catheter displacement. So, what are the studies and what is the Cochrane review on which type of catheter has lesser displacement while positioning?
Coiled are better, sir.
Coiled are better. No, in fact, all the reviews and the studies have shown that the coiled and the straight have similar outcomes as far as malposition is concerned. Now, where was the malposition? I mean, where did the catheter migrate? It was catheter migration, isn't it? It was displaced. So, where was it displaced? Where was the position of the catheter? How do you diagnose that the catheter is malpositioned? How is it diagnosed?
Sir, the tip of the catheter we will see, sir. It
No.
will
On what? I mean, what? How do you
on
see it?
sir, initially we did an X-ray, and
Yeah, so
after
you did a
that
plain X-ray, or you did a plain
we
X-ray.
put a contrast and do a
Okay,
catheterography.
right. So where was the tip?
The tip had migrated to the upper quadrant somewhere in
Which
this
one? Which is the commonest site of migration? Which quadrant?
the left upper quadrant, sir.
Was left. Normally it is the right, subhepatic. The commonest migration occurs to the subhepatic region on the right side. Any other types of catheters that you know of, apart from swan neck and Penchkov?
Mm.
There is a lot of studies now about the weighted catheters, and they have the best outcomes as far as catheter migration is concerned. So these are weighted with silicone, 15 grams. This is mainly used in Italy, and there are many studies in that regard. So that is the only type of catheter which is shown to have the least migration because there is weighting and that sits in the lower pelvis. Okay, fine. So now we'll move on. So he basically had assistant peritoneal dialysis and caregiver was giving, which was a trained nurse. That's what you mentioned, isn't it? What are the different types of fluids that you know of? PD fluids.
So there are bicarbonate based fluids and
No, let's start with the basic fluids first.
glucose based fluids, that is the dextrose fluid that we used commonly.
Right. Right.
Then we have the amino acid based fluids, that is the
So
neutrophil.
which is the second commonest fluid after the glucose? Which are the strengths used?
The icodextrin, sir, it is the second commonest that is used. That is extrin.
What is icodextrin?
Icodextrin is this is 7.5% which is used, and it is
what is it?
the maltose.
What is icodextrin? From where is it derived? What is it and from where is it derived?
It is
okay, you are mentioning maltose. So where does maltose come in the picture?
Sir,
You mentioned maltose, isn't it? So you are right in a way, but what is maltose?
This is starch. That's a glucose polymer, sir.
Yeah, it is glucose polymer, and maltose that you mentioned, maltose is the degradation product of icodextrin. Icodextrin is not maltose. So icodextrin gets metabolized to maltose. Okay. And icodextrin is basically derived from cornstarch. Corn. So it comes from the cornstarch, right? What is the precaution that you take in a diabetic when you prescribe icodextrin?
That while checking, sir, the glucometer that
Very
we
good.
use, sir,
Yes.
it
So what
has
is
to
the
be
yes, correct?
GDP, PQQ. It should not be working on those principles. That is
Why?
glucose dehydrogenase, because it inhibits. So this will give a falsely low value.
You give a falsely low value. Sure. What will it estimate if you use that glucose dehydrogenase method?
The
It will estimate both glucose and maltose, right? So it will give a falsely higher value. So why is that bad?
because somebody who may be getting a normal glucose may be hypoglycemic. So we
Yes.
might
So I
not
mean,
get to know.
right. So he may be hypoglycemic, or you'll get a higher level, you'll treat it more vigorously, and you'll cause hypoglycemia. So what should you use in such a scenario?
The this GDP PQQ
No,
based.
be more specific. No, what should you use? You should use the glucose oxidase strips, which are more specific for glucose. You should not use the dehydrogenase, DHPQ methods. Right. So now coming back to what he used 2.5% 3 exchanges. Is that what you mentioned? So is that a very scientific way of doing things, or you would have done it better? And how? What is the practical?
We would have, sir, started with 1.5.
Yes.
And then, sir, we would have then started adding, increasing the concentration.
So that you have done, no? You've gone up to 2, you've gone up to 2.5%. Why is it not good using 2.5%? What is the harmful effect of using 3,
because
2.5%?
Glucose degradation, this glucose, which is, if glucose is increased, this is going to hamper the membrane function. So long term
membrane function. Okay. So what should be scientific approach? How should it be done? What will you do?
So, sir, we will we will see what we need. We need ultrafiltration more, or we need the osmotic clearance, the solute clearance more, and then accordingly we will adjust the.
You will do a PET test, isn't it?
Yeah.
You do a PET test to characterize his membrane function. So
yeah.
You did not mention that, so I'm not sure your PET test has been done here.
Yeah, it was done after 1 month of it, and they told
you
it
didn't
is
mention that in the history. The history it is not mentioned. So you should have mentioned that, because especially before going on to such higher concentrations of glucose, one should do a PET test. So what was the result of the PET test?
So, sir, they have done a PET test in which they were told that the membrane function is okay. He's an average transporter. That is what was the result of the PET test.
Yeah, but then why was 2.5% used in that case? 3 exchanges. No, normally we don't do that. No, we limit ourselves to 1, 2.5. But as you rightly said, that is harmful for the membrane. So we're talking about different types of fluids. So one is glucose-based fluids. Second is the icodextrin-based fluids, which is available in our country. What is the trade name of the icodextrin-based fluid?
Extrinal.
Yes, correct. Extrinal,
sir. Under Baxter, sir.
Yeah, what is the full name? Extranil.
Extranil.
They're called extranil, right? Now, what are the other types of fluids? You were mentioning some other types of fluids.
So there are amino acid based fluids, and there is
what is that called? What is that called?
Neutrinil.
It's called Neutrinil, which has amino acids. And how many bags can you use per day maximum?
1 bag is what is recommended, sir.
Yes, 1 bag is recommended. How many bags of icodextrin you can use maximum?
1 bag is there is just 1 bag that we are using, but there are studies in which 2 bags have also been used.
Very good. Yes. Why? What is the problem? Why you don't want to use more than 1 bag routinely?
Because the maximum results, you need to keep it for 8 to 12 hours for a icodextrin.
Okay, what else? Yes. One is that you need a long dwell for at least 8 to 12 hours. What else?
And
the same thing again, that the degradation product maltose, which will get absorbed, there's a theoretical concern that can cause problems. There's too much maltose in the body. So you don't want to maltose. But yes, people have used 2 bags per day. Right. Moving on, what are the other fluids available?
So there are bicarbonate-based fluids. There can be bicarbonate alone, bicarbonate plus lactate, or lactate-based fluids.
So which are the bicarbonate-based fluids that you are aware of?
Bicabra is the brand, is the name of the fluid, Bicabra, which is available.
Okay, what else?
Then
what
there is
Physionil. What is Physionil?
Physionil is basically bicarbonate-based fluid in which
how much bicarbonate? Normal buffer is how much? Normally,
7.
No. In normal your dextrose-based fluid, what is the buffer and what amount?
It is
normal. Your dextrose glucose-based fluids, what is the buffer and how much amount?
7.2.
Mentioned it. No, not 7.5. 7.5 is icodextrin concentration. I'm talking about the buffers.
7.2 is what they.
No, madam. No, Nilita. No, not 7.2. You mentioned the buffers. What are the normal buffers? What is the buffer in your
lactate bicarbonate? Lactate, yeah.
It is only lactate.
Yeah, only lactate.
Standard fluids, it is only lactate. It's not a combination. So how much lactate? How much lactate is there?
Sir, I forgot, sir. I don't remember.
You have forgotten. How much buffer is there in our HD fluid? Hemodialysis fluid. What is the buffer and how much is there?
40 millimole is what I think is it.
Yeah, you're right. It is 35. It is 35 millimole. That it is bicarbonate. We don't use acetate anymore. So in CAPD fluid, it is 40 of lactate. It is 40 milliequivalents per liter of lactate. 40. So now coming to your physiological fluids. So how much is it in Physionil? So in Physionil, it is 15 of lactate and 25 of bicarbonate. The mixture of lactate bicarbonate, which you mentioned, but it is 50. There is still lactate of 15 and there is bicarbonate of 25. Right? So the various bicarb fluids. Now, what are the low GDP fluids which are available? What is GDP?
Glycation degradation products.
Glucose degradation products, not glycation, glucose degradation. GDP is glucose.
Glucose degradation products.
Yes. Yeah. So what are GDPs? Can you name one or two GDPs? Never mind. That you can read up. So which are the fluids which have low GDPs? And what is the principle behind a low GDP bag?
So the it has two this there are two components in this bag, sir.
Yes.
So one component is basically we sterilize the glucose at a lower pH,
Very good.
so that
Very
less
good.
of this GDPs are formed.
Very
So
nice. Yes, correct.
so we keep that acidic in one bag, and another bag
Right.
we keep bicarbonate. We break it up, and then we introduce into the patient. I mean,
Right. Very good. So in India, which low GDP bag do we have? Can you name a low GDP bag? Have you used it? Right. So in our country, we have from Mitra the tri-choice, and that has got 3 compartments, not 2. Okay, so we have the tri-choice, which is available all over the country, and it has got 3 bag pouches, so that you can prepare 1.5%, 2.5%, or 3.5% from the same bag by breaking 1 or 2 or 3 of those pouches. So you've got 3 pouches in that. So that is their specialty, right? So that is our low GDP bag. Right. So now moving on. So this patient was using 2.5%, and you said very correctly that there was no probably break in his technique, but still he developed some pain. So what is the definition of COPD peritonitis? How do you diagnose COPD peritonitis?
So for diagnosing COPD peritonitis, out of 3, any 2 has to be present. One is abdominal pain, cloudy, effluent. One.
Yes.
Number 2, either the peritoneal fluid TLC should be more than 100. Or third is any
No, just complete. No, you have not completed.
More than 100, or in case the number of neutrophils should be greater than 50%.
50%.
And in case
Yes.
of APD, we need to have at least, or in which we cannot obtain a bag, a dwell time of 2 hours, and after that 50% should be neutrophil.
Right.
And third is that there should be evidence, microbiological evidence, that is gram staining or culture showing microorganism.
Right, very right. So this is the diagnosis of COPD peritonitis. Now tell me, in a unit, when you want to report COPD peritonitis, what are the various statistical methods by which you report COPD peritonitis as per ISPD guidelines?
Number of patient years at risk of COPD upon the
no, you got it opposite. We're talking
episodes
of peritonitis we're talking about. So what will be the numerator?
Numerator will be the number of episodes.
Yeah, so numerator will be number of episodes, and the denominator will be patient years. And yeah, what is accepted? What is accepted rate?
That is 0.4 is what we are targeting now, according to the new guideline.
You're targeting 0.4. Very good. Mm-hmm. Are there any other ways of reporting which ISPD says? Yeah, ISPD says many more.
Patient-free years of peritonitis, that should be 80%.
Patient-free years means? Patient-free years? Can you specify?
Patient-free years of...
You're again confused. No, it is not patient-free years. It's not patient-free years. You jumbled it up again. No, it is the percentage of patients who are free of peritonitis in 1 year.
Yeah.
Okay, now percentage of patients who are free of peritonitis in 1 year. And how much should that be?
80% is accepted.
Right, so they want 80% should free. What else? What else has been said you should specify? These two are very basic, of course. What else? ISPD has, given these guidelines. They are very practical, very important.
Then
it says that your culture negative peritonitis. How much should that be?
It should be less than 15%.
Less than 15%. What else?
Mm.
You should specify organism-wise number of episodes per year. Okay, various organisms. Which are the organisms which cause COPD peritonitis?
So gram-positive or gram-negative organism it could be. Gram-positive Staph aureus is common organism. Cons or there could be gram-negative. It will be Pseudomonas, Enterococcus. Not Enterococcus. Enterococcus will come in there. The enteric organisms.
Enteric organisms, right? And E. coli.
E. coli.
E. coli as well, isn't it? And many other ones, Citrobacter and so organism specific you should mention. What else? An ideal unit should mention, report all these. What else?
Then pre.
Yes, you're right. Continue.
Pre-PD catheter.
Pre-PD peritonitis, right? So pre-PD peritonitis is peritonitis in the first 1 month before starting the procedure. So after insertion, before starting the procedure. So how much should that be? Less than 5%.
Less than 5%.
Less than 5% of all catheter insertions. What else?
Then, sir, there will be
all your catheter-related peritonitis.
That is from the insertion of the catheter till the start.
What do you understand by catheter-related peritonitis?
From the insertion till the start of the PD.
No, that is pre-PD. No, that we already finished. Insertion till starting, that is pre-PD. What is catheter-related peritonitis?
Catheter-related peritonitis would be because of the exit site or tunnel infections.
Very good, right. So catheter-related peritonitis is exit site or tunnel infections. So how do you, right, so and how much should that be?
0.2 is what they.
Okay, fine. So in this case, you had E. coli as your organism, isn't it? So what does possible cause of E. coli peritonitis? What are the peritonitis you get when you touch contamination peritonitis and
touch contamination could be a possible cause.
So what is the common organism you touch? Touch contamination or leaks, what is the common
so it could be against a gram-positive organism.
Gram-positive, right? It is staph, isn't it? It's staph. So if someone is getting E. coli, I mean, what should come to your mind?
Gut.
May have had it or you may not have had it.
Gut.
Some gut pathology. There could be some gut pathology.
Yeah, it may. Yeah.
So which are the gut pathologies like?
They could be, sir, like gut pathologies like colitis, sir, ischemic colitis,
right. Or ischemic colitis, could be some gut ischemia.
Gut, yeah, ischemic colitis
or perforation.
Perforation.
Or perforation. So that is one possibility in this case. Right. So you gave him antifungal prophylaxis as well, isn't it?
Yes,
that's what
sir.
you mentioned. So
yes, sir.
What do you give normally?
Fluconazole is what we are giving, sir.
You're giving fluconazole. How much fluconazole?
200 mg is what we'll give you 24 or 48 hourly.
What else is recommended apart from fluconazole?
Nystatin is what we can give.
You can give how much nystatin? Okay, it's 5 lakh units QID. Okay, you give 5 lakh units QID. Right. So what do you understand by refractory peritonitis?
So on day 5 of giving appropriate antibiotics, there is no response. That is the TLC is still greater than 100.
Greater than 100.
Peritoneal fluid.
Right. So what do you do? How do you treat refractory peritonitis?
We have to remove the catheter.
You have to remove the catheter. Okay. So now, are there any prognostic marker which will tell you that this patient will not respond by 5 days. So are there
Day
any
3,
studies?
sir. Day 3 TLC is what we see, sir.
Very good. How much day 3 TLC?
Um,
Very good. Yes, you're right.
1030.
Yeah, you're right. So it's around 1000, 1050. So you don't have to
Yeah.
exact figure. Some studies have said 950. So it's a TLC count doesn't come down below 1000, then it's possible that the patient will not respond to your treatment and you will need to remove the catheter. What are the other conditions for catheter removal is required? One
So,
is refractory bacterial.
fungal peritonitis, refractory or relapsing peritonitis.
What is relapsing peritonitis?
Relapsing is that before the same organism before 4 weeks of complete antibiotics.
Right. And what is recurrent?
Recurrent is recurrent is a different organism.
Different organism. Yes. And what is repeat?
Repeat is same organism, but after 4 weeks of treatment.
After 4 weeks. Any other indication for removing the catheter? Apart from what you have said already. One very important indication. One or two more.
Yeah, so there is a refractory tunnel infection or exit site infection.
Right. So if there is a correct. So if the patient has got exit site or a tunnel infection with the same organism
as there is peritonitis, we have to.
Then you have to remove the catheter. Anything else? Any other indication? Is TB peritonitis an indication for removing catheter?
No.
It's not an indication. Very good. So you said that you can give ATT and you can continue. But what is an indication? Possible indication. If it is not TB,
non-tubercular
right. So non-tubercular mycobacteria could be an indication for. Okay, that's fine. So now you can give us the examination of the patient.
On examination, the BP is 130/70, pulse rate 95, saturation 98% on room air, temperature 98.
When you talk of pulse 95, what else should you mention? When you're presenting an exam case,
pulse regular, 95 beats per minute, regular, synchronous with other pulses, no radial or no radiofemoral delay.
Good. What else? And which is very relevant in this case. What else?
It's regular.
You mentioned it's regular. You must mention the character of the vessel wall. Okay.
Yes, sir.
Is it important? Why is it important?
Yeah, because it's a diabetic patient.
He's a diabetic, isn't it? He's a 26-year diabetic patient, so it's very important. So how do you assess or come to the conclusion that the vessel wall is normal or it is hard? What is the feature of abnormal vessel wall? Ask the question.
Sorry? It will be calcified in calcifications of
it will be calcified. Where does the calcification occur in diabetic, long-standing diabetic with CKD? What is the characteristic calcification in a diabetic CKD?
Inside the vest. So you're asking the media, there is.
Yeah, it's a media. It is not the intima, it is the media, which is called, what is the name? What is the name?
Medial calcification. Medial calcification.
Yeah, there's a name to it. There's a name to it. Nokeberg's medial calcification. Right. But then coming back to the clinical question, how do you know that this calcification has occurred? See, you're taking an X-ray. I'm saying on examination, how do you know that the calcification is occurring?
So the character will be of the pulse.
Character? No.
It
Character
will
may
be
not change.
feeble, and sir, once we roll our fingers on it, we will feel that that hard, this hardness of the.
Right, very good. So,
vessels.
characteristic of an abnormal vessel wall is that on rolling, you can feel the artery. A normal radial artery is not felt. You will not feel it. You'll only feel the pulse. You'll not feel the vessel at all. So if you can roll the vessel wall, it is abnormal. So it's very important to mention the character of the vessel wall. Now, in a CKD patient, if you want to diagnose calcifications of the vessels, how do you do it? Apart from this clinical examination, what are the other guidelines? He is a CKD, he's a diabetic. So what is the guideline for assessing vascular calcification? Apart from the simple clinical examination.
So if we see the this ankle in the brachial index, it will be high in diabetics. That is also an indicator.
What are the other investigations which
Image.
are used? Simple investigations for diagnosing vascular calcification. Which is mentioned in, I think, KDO guidelines.
So on imaging also we can see.
Yeah, imaging, you're right. So what sort of imaging? You're right, absolutely right. But what kind of imaging? Which imaging? Very simple imaging.
Sir, even on X we can see, and on CT also we can see.
CT.
On an X-ray, sir, we can see.
X-ray, very good. So what
Sir,
X-ray?
on X-ray also we X-ray
Which
KUB,
X-ray?
sir, if we do X-ray KUB, we can see the iliac vasculature, and then we can.
Very good. So in diabetes, you can see the iliac vasculature is calcified. Anything else which has been mentioned in the guidelines?
Then, sir, we can go up to CT and CT angio.
No, short of CT. CT, of course, will pick up. Lateral X-ray. Lateral X-ray has been given in the guidelines. You do a lateral abdominal X-ray, you'll pick up the calcification, aortic calcification. What else? I think she's net problem. Yeah, so can you hear me? Yeah, so apart from extra lateral abdomen, what else has been advised?
Sorry, the question
Which
is.
other investigation has been advised? Advocated?
For calcifications.
For calcifications, yes.
So Doppler, if we do, sir.
Doppler is for flows. No, Doppler is not for calcification. For flows.
Sir, angio we can do.
Angio? No, angio not. 2D echo for vascular valve calcification. You pick up the valvular calcification. Isn't it? You often find, isn't it? Aortic or the mitral valve calcified. So these are the common tests for finding calcification. Okay, now carry on with the question. Which your examination?
Patient is a conscious, cooperative, oriented to time, place person. He has a GCS of 15/15. He looks lethargic. His general condition looks lethargic.
This is on which day of his illness? At which point of time? Because we have had a long period. So the examination that you're mentioning pertains to which period?
Sir, I took history on day 2.
Day 2 means after admission, or day 2 from symptoms?
He came at night, and in the morning I took the history.
Right. So this is when he came with peritonitis at that point of time.
Yeah.
Right. Okay. Carry
on. Then, sir, fundal examination showed retinal hemorrhages, and then, sir, JVP, it was not raised. I showed there was presence of pallor, no ictus. Then mouth, the tongue was.
In fundus examination, you did fundus, you mentioned, isn't it? So
yes, sir.
in your fundoscope, there is a green light. What is the green light used for? Have you seen your fundoscope? You can change the colors.
Yeah, sir. Red and the green
Yeah.
ones, but I don't use the green, sir. I don't know.
Yeah, so the green is basically red free. Okay, green basically means the red is filtered out. There's no red in it, and that is good for picking up the microaneurysms. So if you want to check out on microaneurysms, green is a good color. What are the other special investigations which can be done in the fundus related to our field?
Sir, maculo, this
You've heard of fluorescein angiography?
yeah, fluorescein angiography. Sir.
Yeah, what is fluorescein angiography?
So that is basically the mapping of the vasculature,
Yes,
the
mapping
retinal
vasculature.
vasculature.
Right. What do you inject?
Fluorescent dye.
Fluorescein dye. Very good. And is it iodine or is non-iodinated? Because it's a common practical issue, when people ask whether you need clearance or not. Suppose they have renal failure, will you give fluorescein or not? So,
yeah, we can give fluorescein.
You can give fluorescein. Sure. Up to how much creatinine and what happens? Have you given fluorescein to a patient who has pre-dialysis or dialysis patient 7, 8 creatinine? What is the problem? So fluorescein is not nephrotoxic usually. There are a few case reports, otherwise it is not nephrotoxic. But then if you give it in renal failure, it accumulates for some time and it causes a yellowish orange discoloration of your sclera and the urine. So this you must explain to the patient, which goes away gradually. This you may or not have seen, but then this important thing you must tell the patient before giving them clearance for fluorescein angiography. So what is fluorescein angiography used for? What is its specific use? Have you seen patients? FA has been done.
Yeah.
It's called FFA, fundus fluorescein angiography.
Yeah. So basically, it tells her the new angiogenesis and what spots.
Yeah, short of angiogenesis, it picks up the microaneurysms and the small your hemorrhages early. Once you have angiogenesis, you don't need fluorescein angiography for it.
Okay.
Yeah, so FA is one test. What else, which is routinely being done by many ophthalmologists? What is its use? Must have seen in your own hospital also. No? It is done very routinely nowadays. One is FFA, and the other is
Ocular, this OCT that we do.
OCT. Sir. Yes, OCT is done. So what is OCT? What is full form of OCT?
Ocular
Never mind. Okay. Yeah, so it is tomography, ocular coherence tomography.
Coherence tomography.
Yeah, but that apart, what is its utility in our context?
That cystoid macular edema that happens is
right. Very good. So it picks up the macular edema very well and macular ischemia. So OCT is very good for picking up these two things. And of course, your routine, you have the color fundal photographs.
Yes.
So routinely done, and that I do. So that picks up the dots and blot hemorrhages as well. Great. So you found some hemorrhages in the eye. That's what you mentioned, isn't it? Okay. Continue the examination.
So then, general examination, sir, tongue was hydrated, oral and hydrated.
Just positive findings. Don't read it, just give the positive findings. Just positive.
So positive, then, sir, in abdomen, there are, on inspection, there are 3 laparoscopic scars that are present.
Yes.
One below the xephisternum and one on the left side and one in the lower abdomen. Sir, there is a scar marker in the right inguinal area. On superficial palpation, there is tenderness that is generalized, and on deep palpation, there is rebound tenderness, but there is no localized pain foci.
Why are you saying that? I mean, what is the importance of the statement? That is generalized tenderness, but no
Because I want to
localized.
rule out, sir, some tunnel infection associated with peritonitis or the so
No, tunnel
rebound.
is different. We'll come to the tunnel examination afterwards. In examination of the abdomen, why is it important to examine and note that there is no localized tenderness?
Because they can be, sir, secondary to some abdominal foci that peritonitis is
Absolutely
occurring.
right. So that's why you want to rule out any local intra-abdominal
Pathology.
Yes. That's why this examination is very important. Let's continue.
Then, sir, at the exit site, there is we examined the exit site, sir. In exit sites,
Yes.
there were no signs of inflammation. There was no redness, no swelling, no induration present. There was no discharge, and we
Very
followed
good. So,
the.
because you mentioned a lot of points of the exit site, what is used with all these signs? You mentioned 4 or 5 signs, isn't it? So, is there any
Signs of
scoring system?
inflammation.
So, is there any scoring system using these 4 or 5 points that you mentioned?
I'm not
Very
aware.
good. You mentioned very correctly that there is no swelling, there is no redness, there is no rusting, there is no discharge. So, you mentioned absolutely right. So, can you go a little further? So there's a scoring system based on these findings that you mentioned. And the total score is more than 4, then it is diagnostic of exit site infection. Right? So these points are very important that you mentioned, and you can make a score 0, 1, 2 for each of these points and come to total. Right. Continue.
Then, sir, there is no tenderness.
Tenderness, you mean the tunnel tenderness?
At the tunnel,
There's
sir,
no tenderness.
when we palpate the tunnel site also, and then we
Right.
do the milking also, and there was no discharge that came, and there is no tenderness. And so positive findings, that only, sir, the abdominal.
You found only that much. Okay. Now tell me, for a patient with suspected peritonitis, any other point of care test you would like to do at this point of time?
Any other,
Apart from
sorry?
your examination.
Sir, sorry, sir. Any other?
Any other point of care test you would like to do? Apart from this clinical examination, which is relevant in this case.
You mean next examination, sir, what I'll be doing?
No. Any other point of care bedside investigation you would like to do? Okay, let me put it more.
You mean
Straightforward.
any other? You mean ultrasound or something bedside?
Yes, I'm in ultrasound. Why you want to use ultrasound?
So
Yes, you're
because
right.
to rule out tunnel infection, sir, we need to see that the area around the tunnel there is some hypoechoic area.
So ideally, that should be a part of your bedside examination, or tunnel examination with ultrasound. Very important. Look for any collection or any other thing. Okay, continue. You finished your examination?
Yes. Also positive findings. So.
Yeah, positive.
Yes, sir. That's it.
Great. So now give me your final diagnosis.
So this is a case of CKD stage 5 on CAPD, NKD probable diabetic kidney disease, underlying diabetes and hypertension, and now presented with PD peritonitis, day 2 of PD, day 3 of PD peritonitis.
Right. Now, how will you investigate him?
So we will obtain the PD fluid, either the bag that has been we'll send the whole bag for evaluation, or we will put in two. If it is empty, if it is dry, then we'll put in dwell for 2 hours, and then we will send 50 ml of it for in the blood culture bottle to the lab, and then we will centrifuge it, and from the centrifuged from uh, the bottom part we will send it for gram staining for
So now what is the method that you use in your hospital routinely?
so we take out 50 ml, we send.
You take out 50 ml from the bag.
Yeah, 50 ml
Okay,
from the
and
bag,
then
and we discard the supernatant, and we send the this thing.
discard the supernatant. Never understood. I mean, you've taken 50 ml, what supernatant? You've taken out 50 ml, where is the supernatant? It is 50 ml of PD fluid. There's no supernatant.
No, sir, we have to centrifuge it, and then
So
we
you're
have.
routinely centrifuging. You're routinely centrifuging your
Sir, in
PD
our
fluids.
hospital, sir, you are asking?
Yeah, in your hospital, in your hospital. What is the practice in your hospital? I'm just asking what is the practice
Sir,
in your
in our
hospital?
hospital, sir, we take it from the bag, sir. We take out around 10, I mean, we take out 50 ml, 10 ml, we send in blood culture bottle to the lab.
You send 10 ml in blood culture bottle in your lab.
Yeah,
Okay.
yeah. And the other sample we send for TCDC and PD count.
And the ideal method you mentioned was you will centrifuge it. You mentioned something, no? So how do you
Yeah,
centrifuge?
ideally. Yeah, so ideally, sir, we will centrifuge, and the supernatant will discard, and the other part we will send in the culture bottle.
Okay. So how long you centrifuge, at what speed? So this is mentioned in the guidelines. You can read it up. Even we are not doing it routinely. So, but from what we have read, that 3000 G for 15 minutes. Okay, and then you'll get a pellet, and that will really suspend in a buffer of 5 ml, and then inoculate that into the blood culture. That will give the best yield. So, what is your culture negative peritonitis rate in your hospital?
Sir, actually, I'm not aware, sir.
You are not very sure. All right. No. Okay. So, what is the duration of treatment which is advised for? So you grew E. coli here, isn't it? It was E. coli. You mentioned E. coli.
Yeah, yeah, E. coli. For
E.
the
coli.
enteric, sir, I didn't mention, but it was E. coli, sir.
Okay, I don't know that thing which came to me, you know.
Yeah, yeah. So that is the investigations that I mentioned.
Yeah,
but
yeah. You mentioned E. coli,
it was
no?
E. coli.
It was E. coli.
Yeah.
So, what is the duration of treatment advised for E. coli?
So for the enteric pathogens, we give for 3 weeks, sir.
3 weeks, and you gave him for how long?
For 3 weeks.
You gave him for 3 weeks. So, which are the organisms for which you give 2 weeks therapy?
So streptococcus we give for 2 weeks. Corynebacterium we give for 2 weeks. Then for enterococcus we give for 2 weeks. Then
Enterococcus, sure it is 2 weeks? No, enterococcus I think would be longer, isn't it? Enterococcus is 3 weeks. Enterococcus won't be 2 weeks. No?
okay.
Cons is 2 weeks.
Cons we
Okay,
give for 2
is
weeks.
negative. Coagula is negative. Enterococcus I think would be 3 weeks. Right. Will you treat enterococcus?
We give enterococcus we give this ampicillin we give this,
yeah, you're right. You give oral amoxicillin. If it is a single organism, enterococcus, you can give oral amoxicillin it's for 3 weeks. It's for 3 weeks. And if it is resistant, then you will give
Then we have to depends on, sir. We will give bank first, and it also
You'll give vancomycin. That's right. Right. So in this case now, what will you do next? He had no interpretation failure, you mentioned, isn't it? He had no interpretation failure. This is a very good thing. Now tell me, what are the other adjunctive treatments which you give in a patient with the CFD peritonitis?
So we will give antifungal prophylaxis, and
Yeah,
we give
that you mentioned.
heparin.
You give an antifungal, right? What
And we
else?
give heparin till the time fibrin is formed. Heparin is
How much?
given
How much
500
heparin?
to 1000 units per liter.
Very good. What else? What else? Anything else you'd like to give?
Heparin, antifungal.
Apart from heparin and antifungal, anything else that you would like to give? Which plays a role in the outcome. You give some painkillers if you've got severe pain, isn't it? You give that. NAC has been advised if you're giving
NAC in aminoglycosides.
Aminoglycosides, you give. Patient may have ultrafiltration failure. Your patient did not have, which is a very good thing, but then it's very common to have ultrafiltration failure.
Okay.
Right? So that you'll have to treat. You have to handle that ultrafiltration failure required with hemodialysis or whatever, increasing the glucose concentration. Patient may need better glucose control if you're increasing the dextrose in his CFD fluid. So all these things one has to keep in mind. Right. So I think you've done well. We have covered most of the things. Now tell me, what is the cure rate of CFD peritonitis? What are recent studies? What have they shown? The cure rate of CFD peritonitis. Your patient did well. That's very good. But overall, what is the cure rate?
So around 70%.
Okay, your guess is, I think, very close to what it is. That's a very high thing. In PD or in general nephrology as such, which are the two important groups, which are doing the observational studies and which have really contributed a lot, because we don't have so much of RCTs and that is not possible also. So observation studies play a very important role in our field, especially in PD. So are you aware of any couple of groups which have contributed a lot? In fact, many of your ISPD guidelines are derived from studies from these groups, which are mentioned in their guidelines.
PPD, groups and...
Sorry, just say that again. You're close to it.
PDOPS is...
PDOPS, very good. So PDOPS, so what is PDOPS?
Peritone.
Yes, P is for peritoneal.
Yes, observational society. This basically...
No, it's not observational society. DOPS is the original group.
Yeah.
So that is the dialysis outcomes practice pattern study. Right. Yeah, so PDOPS is the peritoneal dialysis part. You're absolutely right. So PDOPS has come out with a recent study in which they studied in the developed nations mainly. All the UK, US, New Zealand, Australia, and others. 7-8 countries. And Thailand was the one underdeveloped country. And they found a cure rate of 65%, going down to as low as 54 and little better 68. So it's not too good. So it's just about 65%. And how do you define a PD cure? PD peritonitis cure.
Counts this TLC count less than 100, sir.
Yeah, there are many components to it. No? So that is only one part.
That is song PD. No,
Song
sorry.
PD.
PD.
Yes, song PD is the other
No,
Yes,
sorry,
song.
sir.
No, song PD, you're right. There is a song PD study as well. What is song?
How
You mentioned it, that's why I'm asking. You mentioned song. So what is song?
this that the focused outcomes that we have seen, like we
Yeah, there's
treated
outcomes.
the
Standardized outcomes. Standardized outcomes.
standardized outcomes of
Yeah, very song. So song PD has also published a study. You're absolutely right. So when you talk of complete cure, it means that apart from these TLC rates, which should be TLC should be less than 100, there should be no relapse, no recurrence, and no transfer to dialysis, and no death. Okay, so all these parameters, that is in the SON PD. Okay, so I think we have done more or less very well. Have you heard of simultaneous catheter removal and implantation, and when do you do that?
if it is refractory exit site or tunnel infection, sir, we can do simultaneous. That
When
is
will
at
you
the
do it?
same time we remove the refractory exit site and tunnel infection, sir.
Okay, when will you do that?
I mean, day
You do
after
it mainly in relapsing. Okay, not so much in, can do it in refractory or exercise also, but mainly it is done in the relapsing. So after you've treated the patient completely for 2 or 3 weeks, whatever, when the fluid is clear, then same setting you can remove the catheter and reinsert on the other side. And you can start dialysis the same day. And how do you start the dialysis?
low volume is what
Low
we say.
volume, very good. Low volume,
And the patient has to be in supine position.
supine position, right? And so preferably it'll be day dry, so that we can move out. So that is the simultaneous catheter removal. And okay, thank you.
Okay. Thank you very much, sir. We have learned a lot from this extensive class. And one of our rule is that your opinion regarding Nivita, how she has performed. And
No, she has done very well. She has done very well. Yeah,
okay.
done very well. She knows a lot. Yes.
We just do a summary of what you have asked basically for the students. Today we have more than 140 or 150 students live. Okay. So Nivedha, you have presented a case of diabetic kidney disease with a CKD, and one is a CAPD and developed subsequently peritonitis. And your teacher has asked you what about the native kidney disease? What is the difference between a diabetic kidney disease and a diabetic nephropathy? And what is diabetic nephropathy? Basically, it is a biopsy diagnosis. What are the other features that suggest there's diabetic kidney disease is there? Like there is a proteinuria with bland urine, ultrasound showing a normal kidney, like that. He has also asked about what is NPDR and what are the different grades of NPDR, mild, moderate, and the severe microaneurysm in the mild group, the dot and blot hemorrhages. He asked about the exudate, what is a hard exudate, was it a soft exudate, which one is worse? Hard exudate is a lipid and soft exudate is basically a microinfarct, and that is a worse prognosis. What are the this is a late present. What is about the late presentation of CKD, who needs dialysis within 3 to 4 months after appearance to the nephrologist? The types of PD catheter, about who has detail about the Tenkov catheter. This is a different. This is swan neck, straight tipped, and the coil catheter. And what is the catheter that has been used in your patient? And he has also asked which catheter has a more chance of displacement, and are you aware of any study of not? And next, he has also asked you about how do you diagnose a catheter malposition? How do you do an X-ray? What is the common site of malposition? And any other catheter type about which is lesser chance of the malposition, the silicon weighted catheter. And then he asked about what are the types of the PD fluids, and what is the commonest one other than the dextrose based fluid, what is an icodextrin, from where it is derived, and what is the disadvantage of how do you monitor, or what is the problem with using this, because maltose is a degradation product. So what are the precaution you need? Normal, this is glucose measurement by glucose dehydrogenase method may be fallacious, and in this cases glucose oxidase method is better. And he asked about what will be falsely high or the falsely low. He has rightly mentioned the reason, as well as it will be falsely high, and so there is more chance of hypoglycemia if you over treat it. Then what is about the glucose oxidase stream? He has asked you. This your patient was using 2.5% 3 times a day. He asked whether this is the scientific one or would have been a better choice, whether a PET test has been done or not, and why. Then if it is not done, then why 2.5% has been used, because it's not a common practice. He asked about what the trade name of the icodextrin fluid, and now also about the other types of fluid available, amino acid based fluid, and how many bags you can use in a day in a case of one bag, or how many bags of the icodextrin you can use, and what is the problem if you use a more icodextrin in a day. He has also asked about some physiological or the bicarbonate based solution, and this is how much bicarbonate is there. He has asked you. At the same time, he has also asked what about the buffer in the CAPD bags, and about the lactate, what is the amount of the lactate is around 40 milliequivalent, and what is the normal buffer that is used in a hemodialysis fluid like the bicarbonate, and in physionyl how much lactate is there and how much bicarbonate is there, and he has mentioned 15-25 like that. And what is asked about this glucose degradation product, and what are the GDPs, and what about the solution which have a low GDP, and what are the principle that is behind the using of a low GDP fluid. Name some low GDP bag that is available in India. He have mentioned you about the tri-choice bag prepared by the Mitras, or you can prepare any formulations of 1.5, 2.5, 4.5 by breaking these connections. And next, he has asked you about this. Sorry, as yet, and what about the how to diagnose? Next, he has gone into the right subject of CAPD peritonitis. What is the exact diagnosis? How do you diagnose a CAPD peritonitis? And how to report a CAPD peritonitis has been diagnosed, and different ways to report, the accepted rate of the different in terms of patients and in terms of the episodes, and what are the other method, the percentage of patients that is free of peritonitis at the end of 1 year, and what is the acceptable rate. What about different ISPD guidelines? He has asked about what should be the percentage of the culture negative peritonitis. It is less than 15%. He has mentioned. Specify he has asked about this organism, about the gram positive and the gram negative organism, and what is a pre-PD peritonitis, what is a catheter-related peritonitis, and what is exit and tunnel. And he has also asked you about this, the cause of the E. coli as a cause of peritonitis in your case. What about the gut involvement in these cases, ischemia or a perforation that should be considered in such cases. And what is the next? He has asked you about any what additional thing you can do about the antifungal prophylaxis, which is a better prophylaxis, and what else you can do other than this fluconazole. He has asked you about this, what is a refractory peritonitis and how to treat a refractory peritonitis, what is the prognostic marker which can suggest that this PD may not respond. At the end of the third day, you can test the count on the fluid. What are the other indications of the catheter removal? He has also asked about what is the relapsing peritonitis, recurrent peritonitis, the repeat peritonitis, and what are the other indications of the catheter removal, and whether the TB peritonitis is an indication of removal or not. What about the non-mycobacterial tuberculosis peritonitis? And then after this history in the examination part, he has asked you what you should mention other than the rate in the pulse, how to detect this is calcification is there or not in the radial pulses. How do you know that the vessel is calcified? Which layer of the vessel is calcified? If you can roll the artery, radial artery, other than filling there, you should consider there is a calcification. And then he asked what about the other things you should do for diagnosis of calcification like X-ray of the KOB or a lateral X-ray of the abdomen, or you can otherwise do a 2D echo which just detect the calcification as in the valve calcification in the heart. And which day of the illness I have examined, he has asked you. And in the examination of the fundus, he has asked you about the utility of using a green light, and what are the things, what are the indications of doing an FFA, whether it is an nephrotoxic or not. How do you make the patient cautious about the different discoloration of the sclera or the in the subsequent period? What about the fluorescent? What other investigation simple that is done commonly like OCT to detect the macular edema or the macular ischemia? In the examination part, in the abdomen, he has asked about the difference of importance of the difference of a local and a generalized tenderness, and if you get a local tenderness, what does it detect? How to examine the exit system you have mentioned, but he has asked about some scoring system which can more precisely and definitely can diagnose if a more score more than 4, that is the cause of, there is a more specific for a diagnosis of this kind of infection. And this is if you suspect an peritonitis, what other point of care examination at the bedside you should do. That includes your USG examination of the tunnel that gives you many information regarding the infection. And after the final diagnosis you have made, he has asked what is the ideal method of the fluid test and how to collect the fluid, and what is the practice in your hospital, what is the best method, how to centrifuge, if the best method is practice, then how to centrifuge in which rate and for how many time. We has asked you about the duration of the treatment if your organism is E. coli, and what are the treatment duration for other organisms like a gram-positive organism, Staphylococcus or maybe Enterococcus. What is the drug of choice of this enterococcal infection? And then what should be the additional treatment in such cases of the like antifungal, it may be painkiller, it may be some amount of heparin like that. There is many of the cases of the peritonitis of an ultrafiltration failure. So how to treat this ultrafiltration failure? What is the cure rate of the peritonitis? What are the asked about the two groups, which gives us the observational study, but gives most of the data regarding the different guideline formulations. And he has also like the DOBS guideline, and he has also asked you about this PD peritonitis. What is the PD peritonitis? A complete cure, like a no recurrence, no relapse, no death, no conversion to dialysis, hemodialysis, like that. And at the end, he has asked about the simultaneous catheter insertion. What about this? How to do it, and what is the importance of doing it? And with this extensive session and very knowledgeable, very encouraging session of the peritonitis, he has completed. So thank you, sir, very much for this.
Thank you. You've done an excellent job, noting on everything and
Yes.
recapitulating everything. I mean, you've done a lovely job, I must say.
I just listened and made a note for your whole class, and after that.
So I hope everyone finds it useful. I mean,
Sir, okay.
Very pleasure.
Thank you very much. We today almost 150 students, including this YouTube, and they have attended all over the country on all parts. So in some future classes, we'll be calling you. Next will be our OSKI session. If you wish, you can stay. But
sure.
Okay. So over to Aniruddha to start this OSKI sessions. Nivida, you just read and try to answer it.
Thank you.
Thank you, sir. Screen is visible? Is my screen visible? Yes, sir, it's visible. So a 25-year-old male, non-diabetic, non-hypertensive, with weakness, fatigue, on and off body aches, occasional flank pain. CBC 12.7 hemoglobin, 6500 TLC, 185 K platelets, creat 1.1, fasting blood sugar 88, TSH 1.89, and sodium 138, potassium 4.5, calcium 11.9, and phosphorus 2.8.
Yes.
Albumin 4.3, and urine showing RBC of 8 to 10 and pus cells of 2 to 3. And albumin is traced. So there is hypercalcemia, so maybe some stone which is causing infections and flank pain.
Yes.
PTH, we will order for the X-ray KUB ultrasound, maybe PTH because phosphorus is also low, and vitamin D. Vitamin D is low, PTH is little high. I mean, it's 98.
It's a normal patient, not a CKD.
So there is calcification that we can see in both the kidneys, and that is in the medullary area. So medullary calcification. The medullary calcinosis, and what will you do next?
So, which kind of investigation it is?
This is CT, we can see, and we can see the kidneys, and we can see calcifications in the medullary region. Medullary nephrocalcinosis is what we should, it would be one of the possible diagnosis.
This kind of a parameter.
Do next means investigation, so you're asking?
Investigation. No. You have a
So parathyroid scintigraphy.
That means you need a
scan
nuclear scan or what? Isotope scan? What is
Yeah.
it?
So yeah. So we can see one of the glands that is
The two types of investigations that they are using.
so this is an ultrasound image on the on this side, the first image.
Yes.
This image is showing the thyroid gland, and below the thyroid gland we can see the parathyroid, which is enlarged. Hypoechoic, enlarged.
possibility of
Yes.
Parathyroid adenoma.
What about this one?
In which the uptake is seen, and this is away from the parathyroid gland down. So there is some ectopic
Actually, what kind of isotopes can you do? Because there are so many glands, thyroid, parathyroid, lymph nodes, and eggs.
so scintigraphy is what we do.
Yes. But you use two types of isotopes so that one can be taken up by the parathyroid and other background, and thyroid they can take other scan, other isotopes.
Iodine technique, technetium.
Yes, ideally strontium, technetium, the two are used. Okay, but here it is a simple technetium scan. What can you see?
So there is an increased uptake in one of the glands.
Areas, yes.
Yeah.
So what
So it okay. So this is an inferior gland that is an increased uptake.
right.
the system it is. Technetium maintenance system.
Technetium.
Yes.
Parathyroid adenoma.
How will you manage this issue?
So since since it is having a medullary calcinosis, and also the calcium level is high, so we can go for a parathyroidectomy.
Okay. So that is the second question. Today's questions are a bit easy. So
25-year-old male, non-diabetic, non-hypertensive, complaints of weakness, fatigue, on and off, body aches, CBC 12.7, TLC 65, platelet 185K, sodium 138, potassium 4.5, creatinine 0.9, calcium again high 11.9, phosphorus 3.1, fasting 88, albumin 4.1, 1.89, and then urine is showing trace albumin. So normal creatinine with high calcium, and the symptoms are mainly because of hypercalcemia. We would like to do again vitamin D and PTH. So vitamin D is low, 18.1, PTH is 90. So low vitamin D, but a high PTH. So PTH more dependent hypercalcemia. So could be there's a in the left and the right kidney. There is calcified weak calcified lesion.
Yes, see, this time there was no hematuria, and this is USG that is slightly different from the last USG.
Yeah, this is calcifications. That is metastatic calcifications, or like some malignancy because of which.
So not very sure about the calcification. Maybe or may not be like that. Huh?
So USG no evidence of recognition system will be scanned.
Any kind of uptake.
There was no obvious uptake. Hmm?
Yeah.
Hmm?
So,
Okay.
I can't.
Next.
So it could be, sir, maybe some malignancy we should rule out to see some PTH related peptide which is causing this
Here PTH is
increase
high.
that is acting on the parathyroid gland, leading to this increase in calcium.
So no mention about related peptide, but the PTH was high. Calcium was high. PTH was high. Vitamin D was low. There is not much in the USG. There was no adenoma in the scan.
There is
So
urinary 24-hour calcium.
if you are given these investigations, how do you interpret this?
24-hour calcium excretion is 150, and urinary calcium recommendation is 0.0. Distal RT.
What about this
RT.
calcium excretion? It is normal, high, or low? And if you see the ratio also.
It's lower than sir,
Yes.
normal.
Yes. Then if it is a low, if the patient is hypocalciuric, then what is your diagnosis?
Hypercalciuric, this familial hypocalciuric hypercalcemia.
Yes. So is it a genetic condition?
It's a familial condition, so it runs in families. There is no evidence of hypercalcemia in first degree relatives. Next.
Next.
Genetic testing we have done,
And what
in
we
which FF gene they have seen it is hemizygous pathogenic. So it is a pathogenic gene. It is present. This pathogenic variant was present.
now you tell the diagnosis. Is a hypercalcemia, hypocalciuria, genetic one, non-parathyroid adenoma.
Familial hypocalciuric hypercalcemia.
Yes.
That will be the diagnosis.
We have given you in this way so that you can go home and you can read and you can remember. Okay. So Anurita.
So in very severe cases, we give cinacalcet.
Yes. That is this molecule.
Otherwise, mostly it doesn't require much of treatment. Mainly there are 3 main mutations. Our patient had a mutation in the CSR, that is type 1 familial hypocalciuric hypercalcemia. And normally what happens in this disease is there is a shifting, there is a right shift of the set point of the activity of CSR because of an inactivating mutation. So that's why you require more than normal blood range of calcium for inactivating the CSR receptors. And primarily, it can masquerade as a primary hyperparathyroidism, especially if you have a asymptomatic to mild to moderate hyperparathyroidism, especially when you don't have other aggressive manifestations. So in that time, usually primary hyperparathyroidism is something which is much more symptomatic. You have decreased bone densities, as well as you may have other adverse events like calcifications, like nephrocalcinosis can be seen in case of primary hyperparathyroidism, which is usually absent in case of familial hypocalciuric hypocalcemia. And in case of primary hyperparathyroidism, you may get recurrent nephrolithiasis, which again is a bit rare in case of FHH. And FHH usually being benign, you don't require to treat. Only if you have much of symptoms and you get increased calcium, you may consider treating using, as you said correctly, with cinacalcet. So coming to the last question.
One second, sir. Sorry. So it's a 55-year-old male, hypertensive since 10 years on amlodipine, poor appetite, malaise, body ache since 2 to 3 months, on and off frothy urine and reduction in urine output. Hemoglobin is low with normal TLC and platelets, and then creat is high. Second, this sodium is 128 and potassium is little high. Calcium is high, phosphorus 3.7, albumin 3.23. Albumin is 1 plus in urine. So most likely it's a renal frothy urine. So there would be some proteinuria and some GN, because of which there is a renal failure. And its hemoglobin is also low. That is 6.7. So it's a probable CKD. Sodium is low, maybe dilution, and the urine output is also reduced.
If you get a patient of hypercalcemia with anemia, with a high creatinine, with minimal.
So myeloma disease is what we should make a possibility, sir.
Next.
2D echo has an 24-hour urinary protein 1.9, and then USG showing right kidney of 9.2, left kidney 10.1, bilaterally raised echogenicity. So again goes in favor of myeloma, and there is LVH. So should look for amyloidosis also as a possibility. This is C3 is 96, serum electrophoresis is showing M band. So myeloma disease with the restrictions. Ratio is 4.57.
What about this free light chain?
Kappa lambda ratio, sir, if you see this race, so there is a low, this lambda, kappa is more and the lambda is less. Restriction, right? That is what we is, and there is M band. So mostly said it is myeloma disease.
For need a more specification, that is the quantity is important. M band, you need the percentage, how much percentage it is and what is the quantity. And in the free light chain, in presence of renal failure, you should take, because they are not very high, more or less in the true value is in the normal range. Ratio is high. Okay. So need to confirm the diagnosis.
So we would, sir, we would go for a bone marrow, sir. And if bone marrow is not suggestive of anything, I mean that plasma cells are not meeting the criteria, then we would biopsy the patient.
We did a renal biopsy for this patient. Bone marrow plasma cell was less than, I think, 10%. So renal biopsy was done, and this is the biopsy image.
So this is a pass.
You just describe what is the stain, what do you see?
This is a renal biopsy in which we can see the eosinic material, pale eosinic material that we can see.
Yes.
And this is probably PAS stain, which is PAS positive. PAS stain positive.
Which one is first and positive?
So this, sorry.
As positive, you were telling this is eosinophilic material, but you were telling past 10 at the same time. These are contradicting.
Yeah, so this is probably a PAS, PAS stain slide, and this is PAS positive, this cast that we can see.
What kind of cast?
Likely a light chain cast, sir.
It is not possible to tell from this picture the light chain or a cup or a heavy chain.
Yeah, probably, sir. I'm not sure.
Okay. What is classically called? Arrow
So
is there.
cast.
Hmm.
Cast is the
Okay.
light chain. Cast is here.
What about this?
So this is
This is the immunofluorescence, indirect immunofluorescence.
kappa is what?
Very prominent.
Kappa is what is very prominent.
The cast you can see now the kappas. Huh? And next, I need to give something lambda now.
Lambda is not that.
So you call it a immunofluorescence restricted to one chain. And
Okay.
Yes. It is restricted to kappa. Lambda is
Kappa.
not. So then what is your diagnosis?
LCCD.
Okay. Anirudh.
The light chain cast nephropathy, as you were correctly saying, these basically are completely past positive. If you have a past positive tendency, it's going to be pain. These are light chains, so these are mainly not having carbohydrates, and they typically show the fractured casts. The light chain casts are supposed to be fractured, and this clearly shows the fractures. And again, here it's very evidently kappa positive. So the images were done for the skeletal survey of this particular patient. And what do you see in the skeletal survey?
This osteolytic lesions, lytic lesion, that is classical of myeloma.
Multiple myeloma. So
Multiple myeloma.
we have multiple myeloma defining events. So evidently the diagnosis is
Myeloma, and we will start with SIBOT, and we will, if not responding, maybe plan for a transplant, bone marrow transplant.
would you consider any kind of additional therapies or extracorporeal therapies considering a light chain cast?
Hmm. So you mean to bring down the calcium?
Not to bring down
Bring down
extracorporeal
the light
therapies
chain.
to bring down the light chain. Is there any role of any extracorporeal therapies?
Okay, go ahead.
Extra. Class.
Not in this case, but here because the light chain is not very high.
Then plasma pheresis, I'm not sure, sir.
Yes, somebody has raised. Yes. This is called a
Either
Yes.
is a heme, either we will, sir, this that hemodial or sir plasma pheresis.
it's called a
Very
high
sure,
cutoff
sir.
dialysis. No? It's
Cycles of plasmapheresis can be used when you have a very high light chain load. Especially when usually the involved FLC is more than 150. It was not there in our case. And if you have a presentation with acute kidney injury, then you may consider using plasmapheresis, which was much is comparatively more efficacious than the high cutoff dialysis. Okay. This concludes the OSKI session.
so at the end there is only 5 minutes left. I think Aniruddha should tell something about this, our last one. You just listen to this. This is a Organ Transplantation Act in a nutshell, so that you can tell in your exam and you know the basic things. Just listen.
This is just a brief summary of the quota act, which usually comes as many times has come as questions. So the medical legal aspects of transplantation and what a nephrologist needs to know. Primarily, act is a law that is passed by the legislature. Amendments are small modifications.
Slides, basically, you not cannot see the slides.
Okay. It has been paused by the admin. Is it visible now?
Yes, yes. Make it full screen.
So we were talking about the medical legal aspects of transplantation, what a nephrologist needs to know. Mainly, a act is a law that is passed by the legislature. Amendments are the small modifications which are done to improve that. Rules, as because there are certain lacunae in that which are not complete. So the rules can be laid into complete those portions. The main aim of the Transplantation of Human Organ Act was to regulate the removal, storage, and transplantation of human organs for therapeutic purposes to prevent commercial activities to that. So, coming mainly to the modifications, it first came in 1994, and after that, it came as an act. The next act was in 2011, and then in 2014, finally, we had amendments in the rule. And if we look at the main changes which have come from 1994 to 2014, that usually that what has happened in 2014, that the advisory committee was defined, the appropriate authority was again defined, and the authorization committee included hospitals as well as the state. The this brain death declaration team was expanded, included the physician, anesthetist, and the intensivist. And also again, the scope of swab donation was included, and the scope of including grandparents and grandchildren in the near relative was done. Number of forms were increased, was simplified, and it was made from 13 to 21. And also the role of other NGOs and other recipients in the organ retrieval was included. So coming to the regulatory bodies, mainly there are appropriate authority, advisory committee, authorization committee, competent authority, and the medical board, which declares the brain death. Now coming to the advisory committee, which mainly helps out the authorization committee, it's constituted by the chairperson, in which there is a state government secretary and two other medical experts. It is actually the of a civil court to look at the violations and investigate kind of violations. Now coming to authorization committee is headed in two places. In hospitals, if they do more than 25 transplants per year, and in the state or the district level, if the hospital is doing less than 25 transplants per year. And the authorization committee actually would be headed by a medical practitioner and other two senior RMPs, as well as to be headed by the Secretary of Health or Director of Health and the nominee, and other two non-medical persons having high credibility. In the hospital, it has to be led by the medical director or superintendent, but the persons and the doctors who are involved, they should not be the part of the transplantation team. Now, this authorization committee would regulate the live donor transplantation, and it would actually look into the relationship between the donor and the recipient, and if there are any commercial inklings involved in this, and any kind of decision can be again appealed against in the central government. The competent authority sits in the hospital, is directed by the head of the institution, and the members again are not the part of the transplantation team, and it's only valid for near related transplantation. And then the medical board, it actually looks after the definition of declaring the brain death, and again is headed by 4 panels of doctors: the hospital administrator, the RMP appointed by the medical superintendent, the neurologist, neurosurgeon, the physician, the intensivist, and an anesthetist should be involved in that. So if we look at the type of organ donors, apart from the deceased donor, the living donor has now expanded to near related. Spousal is again being considered in the near related, non-near related, and brain donors. And under this near relative, in 2014, we can also include the grandparent and the grandchildren. Any other persons apart from the first degree relatives would come under the purview of non-near relative donors. The other donors are the disease donors. So if we look at the who gives the regulation or who gives the permission for each of this, mainly for near related, for Indian national, it has to be given by the competent authority. That is the head of the institute. And for any other transplantation apart from near relative is headed and seen after by the authorization committee. For foreign personnel, it's always by the authorization committee. Now there are 21 forms. Primarily, if we look at the function of these forms, for mainly our near relative, form 1, 2, 4, and 4, 5, and 11 are required. For other than near relative, usually 3 and 11 are required. Form 11 being this application to approval from a living donor transplantation. It's common for all the live related donors, live donors transplantation. And for any kind of transplantation from diseased donor, form 8, 9, and 10 is required. And for applying for a voluntary donation, you have to fill in through the form 7. Now, again, this slide looks into that. Now, for live donor scenarios, for near relative, we look at the competent authority, and for any kind of foreign national, it has to be through the authorization committee. But the other reason remains a very big gray zone where the definition of altruism is not very clear cut. Whenever we have a foreign donor and recipient, for any foreign donor, for an Indian recipient, it's only the near relatives which are allowed. For a transplantation between Indian or donor to a foreign recipient is not permitted. And a foreign donor with a foreign recipient, if comes from outside, the permission has to be taken from a senior embassy official through the form 21. And in case of the country is not having an embassy, the certificate of the relationship has to be issued by the government of this country. And this again looks at these are the forms. The form 4 is for the fitness of a living donor. Form 5 is given by the pathologist to certify the genetic relationship between the live donor and recipient. And form 6 is spousal living donor. And form 11 again for generalized living donors. And form 19 is for the near relatives other than spouses. And in case of foreigners, then in case of foreigners, it has to be, this is form 21, which is filled by the embassy. Again, the brainstem death, which is confirmed after the neurological examination, documentation of the ancillary tests. And for consent regarding the removal of organs, the main consent is given by the family. For any kind of unclaimed body which is not claimed within 48 hours of the death, is under the control of the hospital. And for post-mortem cases, it again comes under the purview of superintendent of the police or the deputy inspector general of the police. So section 18 of this particular act looks at the punishment for these kind of removal or human organs without any authority. Punishment can be from 3 to 10 years of imprisonment and fine ranging from 5 lakhs to 20 lakhs. And section 19A particularly looks at the commercial punishment for commercial dealing in human tissues, where the punishment can be from 1 to 3 years of imprisonment and fine of 5 to 20 lakh of rupees. With this, I would like to conclude.
Okay. Thank you, Aniruddha, for this brief presentation. So with this, after this long class, we end our class. Thank you, Nivedha, for being with us. And my thanks to your teacher, Dr. Santosh Bhargis, also for allowing.
Thank you, sir.
And I think this class may be helpful in your exam. And thanks
Thank you,
to
sir.
our technical team, especially Mr. Amol is there throughout. Mr. Sai Mitra is there, the Ashish is there, and Kuntal is there, and everyone. I thank everyone for this attending these long classes and helping me throughout. So we'll be having our next classes maybe 2 weeks after this. We'll announce some time. Thank you, everyone, and good night.
Thank you, sir.
Thank you, sir.
Thank you, sir.